I'm really pleased to be here. I've learned a lot today already, and this is very important stuff we're talking about. There's no question about that. Nonetheless, I must begin by saying I'm sort of taken aback in terms of the rhythm of this panel by how much I agree with Amol's analysis of the situation and of what we sort of need to do going forward. And I guess what I basically want to say is an elaboration on that. The very title of this panel, as Richard knows, sort of set off alarm bells with me in my mind, because I just think that the question of payment system incentives, particularly when you're talking about improving quality, is just the wrong place to start, and is not immediately relevant to what most of our problems are. And there are three basic reasons I think that, which I'll talk about in orders of ascending importance. The first is that perhaps because everyone in the healthcare system tends to be so preoccupied with money most of the time, I think there's a very exaggerated view of the ability of payment policies or mechanisms to actually affect the way in which care is delivered. I think they can, to some extent, more with physicians and to some degree hospitals than certainly with nursing homes or community-based services. But even there, I was really struck by David Rubin's comment earlier today, and I have great respect from David. I've learned a lot over the years, but somebody asked some barriers to adoption of the UCLA Alzheimer's care model, and the first thing he mentioned was, well, hospitals don't get paid for it. Well, that reflects a fundamental misunderstanding. We're talking about Medicare patients. That reflects a fundamental misunderstanding of how hospitals get paid by Medicare. And in fact, hospitals do get paid for it if they want to do it, because if you have a patient with a given diagnosis, you get paid the same whether you have a nurse practitioner working on shortening the patient's stay or improving their discharge or improving the quality of care they get, than if you don't. You don't get paid for having a registration. You don't get paid for maintenance of your operating room. You get a lump sum based on the diagnosis and complications of the patient. And how that sum is allocated, in principle, is entirely at the discretion of the hospital, as long as it meets standards of professional care and the conditions of the Joint Commission. Now, in fact, most hospitals don't behave and budget that way, but the issue of changing patterns of care within a hospital in order to improve care of patients with Alzheimer's payment may or may not be a barrier to it. It may also be an incentive to do it if you reduce length of stay, for example. But I think the kind of response that David was not saying that analytically himself, he was reporting that's what people in hospitals tell him, because that's what hospital finance departments and CEOs tell directors of nursing when they want to add new lines or a new service. We don't get paid for it. Well, you don't get paid for anything. You don't get paid for your salary. You get paid a lump sum, and you are free to allocate it however you want, as long as you meet regulatory and professional standards. And we've played this game back and forth in the healthcare system, at least since we started doing DRGs 40 years ago. And it's remarkable how little of that game has evolved in that regard. We don't have a payment mechanism problem in care for patients with Alzheimer's, but we have a major problem of payment. I always used to say that there are three dimensions to the question of how any provider of services or system of services get paid. The first question, which is quite critical when we talk about Alzheimer's, is who pays? The second question, which is often very important, is how much do they pay? The third question, which is a lot more fun as an intellectual challenge, and on which I and many of others of us have spent a good part of our professional career, is what mechanism do you use to pay how much you're going to pay them? But from the point of view of the overall health system or an individual healthcare organization, that's the least important of those three questions. And that's our problem when we talk about ADRD. Outside of hospitals, to the extent there is public payment for Alzheimer's care, it's through Medicaid, as is for all forms of long-term care, for that portion of the elderly population that qualifies for it. And I will say as a flat assertion that we can talk about more, that as long as we rely on Medicaid as the principal way in which we publicly finance long-term care in the United States, we will never have an adequate long-term care system. Because the basic incentives in Medicaid management are that the program is controlled by state budget offices, which are under constitutional requirements for balanced budgets, although some are more skilled at evading those requirements than others, and for whom the people with Alzheimer's are not the constituents they are most interested in appeasing and so forth. Medicaid is never going to permit us to have an adequate system. The second point I want to make, and it's non-trivial, but it certainly was overlooked, I think, in the title of this panel, was there are lots of ways to improve quality of care without financial incentives. And I was the member of the Quality Improvement Committee of the largest nonprofit healthcare system in the United States in the early 2000s, when we adopted all the IHI bundles before there was any incentive in the Medicare payment program to do that, because it was the right thing to do and it was good care. And net, we believed in the notion that good care should not be at least more expensive than bad care. And that was largely our experience in that regard. I don't know, Terry, what the experience with age-friendly hospitals is, but Medicare is not paying them anymore for improving the quality of care to elderly patients. And they're all doing it, and they're happy they're doing it, and some of them may be making money in the process as well. But so the notion that somehow, I mean, health professionals and healthcare organizations, with the exception of nursing homes, by and large want to do the right thing. And they're not motivated entirely by money. The behavioral evidence is overwhelming to that effect. And so the notion that that people won't improve quality unless you bribe them is just not consistent, I think, with the historical evidence, even in recent years. But the most important issue that, and I think I'm all hit on it entirely, to talk about reforming payment without having a system to put the payments into is really the ultimate kind of cart before the horse. There are three principal arenas, as we've seen in several presentations today, in which people with ADRD receive health services. They receive them in hospitals, and there are things we can do to improve their care in hospitals. Whether we have to change payment mechanisms or not to do that, I think is something we could debate. We probably do need to kick primary care physicians in some way to get them to be better about initial assessment of patients with potential cognitive impairments of one kind or another. What the balance there is between training and professional standards and payment, we can figure out relatively straightforwardly, I think. The second part of the system, and the part where, in fact, people in the later stages of ADRD are in many instances best cared for is nursing homes. And of course, we just have a 600-page report from the National Academy about all the problems in quality in nursing homes and the things we have to do to improve quality in nursing homes. As Terry and I have discussed, the findings of that report and the recommendations are distressingly similar to the previous report from the National, what was then the Institute of Medicine, 35 years ago, for which I was on the committee, and we are back where we started, except we're paying 3 or 4 times as much per nursing home resident. We don't have many more nursing home residents than we did back then, but we don't have, we haven't fixed those problems. And the evidence we have on value-based payment for nursing homes is, unless you audit the hell out of them, they're going to cheat and they're going to lie, and you're going to pay bad nursing homes more than you pay good nursing homes. So we need more systemic reform of that industry before we can talk seriously about value-based payment for nursing home care. Finally, most people, 75%, I think you said, Thais Marie, with advanced ADRD or with anywhere on the spectrum, who are receiving some kind of care, are receiving it at home. And that's where overwhelmingly people want to be, or where we think people ought to be. And there, as I think we know, we have no infrastructure and no system at all. We have a terrible shortage of workers. We have no effective, comprehensive quality standards for in-home long-term care at all. People are working on them. They're working on them very fast, but they ain't there yet. And we have no organizational infrastructure with which to manage human resources issues, to manage payment issues, to receive some kind of incentive-based payment, to oversee quality, to report quality, to talk to customers at all. It's the Wild West out there, as I think you know, and there's 2 worlds. There's a private home care agency, which is a private home care market, which is purely the Wild West, and then there's Medicaid home care, which pays exorbitant overhead to a bunch of employment agencies to put home care aides into the homes of clients. And DSNPs and all the other dual plans haven't done a goddamn thing to reform that industry at all. In fact, they're not incented to. They have disincentives to. And in addition to all these issues, a central problem, which has been identified correctly many times today, is that these 3 parts of the system don't talk to one another and don't have any way effective to communicate. And if there was a symbolic issue that I would point to relative to all of this, it's the exclusion of nursing homes from meaningful use funding at the beginning of the Obama administration. They were just left out. Partially because, or largely because, I think the attitude of most policymakers towards nursing homes in the last generation is to hope they go away. We're better off without them. That's rebalancing is another reflection of that. So let me just make one last point. I'm over time already. I got red lights flashing at me. Most of the in-home care, which is most of the care for people with advanced Alzheimer's, that is not provided by family members whose needs are totally unaddressed by payment systems, and I don't know what we're going to do about it, but we need to do something about it. But where payment is involved at the moment, most of that care is being provided by underpaid women of color, many of them immigrants. We talked about this morning as an equity issue. It's more than that. It's a quality of care issue. They're doing a very hard job of a kind with which most of us in healthcare, whether we're clinicians or health policy nerds, have very little firsthand experience. I had to cover for my relative's home health aide for 4 hours several months ago when there was a scheduling screw-up. I couldn't wait to get out of there. It was and it was my relative. It was somebody I had a lifelong relationship with. And unless we're going to address the needs of that workforce and the training of that workforce and the management and supervision of that workforce, we're never going to have an adequate system for caring with people with Alzheimer's in this country. And it's going to cost us a lot of money to do it. Because there aren't enough folks doing it at the moment, and those who are still badly underpaid. largely have no benefits and no career ladders and very little training or further opportunity. So I've talked too long already, but I'm happy to answer questions.